بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم. مرحبا بكم جميعا في بكم. استأنفنا نشاط الجمعية السودانية لتصوير الثدي، والذي توقف بسبب الحرب والأوضاع في بلادنا الحبيبة. نسأل الله أن يعم الأمن والأمان في ربوع بلادنا، ونرجع نبنيه ونعمر بأيادينا وأيادي أولادنا بإذن الله. كان من المفترض يبدأ هذا النشاط على منصة سيدرو، ولكن بسبب بعض المشاكل التقنية سنبدأ هذا النشاط على منصتنا لحين إشعار آخر إن شاء الله. وبإذن الله نستهل نبدأ أول محاضراتنا مع قسم علم الأنسجة، ولهم منا كل الشكر على دعمهم لأنشطتنا واستجابتهم. ونستهل برنامجنا العلمي مع الدكتورة نادية الضوء، استشارية علم أمراض الأنسجة بمستشفى سوبا ومستشفى رويال كير. تفضل يا دكتورة نادية، مشكورة.
السلام عليكم. أنا نادية إبراهيم أبو الفتح الضوي. بديت consultant histopathologist، بديت 94 بعد الديجري. بديت في معمل ستاك، نحن بنقول له we still like to call it معمل ستاك. It is now the public national health laboratory. Today I'm going to talk about how we handle a specimen when it comes to the histopathology lab. And I hope it would be interesting to you how this has developed. This lecture is more like, I will quote how somebody described it as a nostalgic trip. It is nostalgic, but the way how we handle specimens in the lab, in the basis, inside the lab, it is still the same. The processing of the specimen is the same, although now we are using very high technology, and we are making use, like all other branches, we are making use of technology to make the reporting easier in the lab and the work in the lab easier. So let's get started. I cannot move the slide. Why? Yes. Now the outline of the lecture, I'm going to talk about the histopathology department, quality control, reporting systems, histopathology request form, one of our real essential points, handling of the specimen, grossing, processing, and reporting. The histopathology department is composed of a team of workers that have to work together within the makeup of the hospital or the medical facility. So the team is composed of histopathologists, technologists, lab assistants, secretaries, porters, and many, many others. And the departments in the lab, can we go back? I need to go back. Just a second. And the departments inside the histopathology, the units inside the histopathology department, a very important one, the starting one is the receiving and registration, the grossing room, the main lab, special laboratories for different things, immunohistochemistry, immunofluorescence, electron microscopy, frozen sections, and you can go on and on. Now, reading room or reporting room, we call it. Report management. So after the report is written, it needs to reach the unit that requested this investigation or the patient. Then archives and stores. So here in diagrammatic form, it is sampling. So this is a section that is sometimes not in our hands, but we get involved in it very much. And registration, when we receive the sample in the lab. Macroscopic grossing, that is a macroscopic examination, which is grossing. then preparation of the slides and cases, microscopic reporting, revision, validation, and sending out of the results. In all these stages of the lab, the most important thing is quality assurance. And this is done in 3 stages. We divide them into pre-analytical, analytical, and post-analytical. And in the pre-analytical, it is mainly, let's finish this slide. It's in the pre-analytical, it's one of our sore points, as I said before, because it involves the step that is outside the lab. And there we need to get involved, like the theater and the transport of the specimen from the theater to the lab. And you can imagine how long this transport can be if as is in Sudan, that the specimen is given to the patient to deliver to the lab, something that nobody thinks should be done anymore. Then another point is the turnaround time. This is, I think, if you are talking about quality, it's one of the major markers that gives you a feedback of how quick the patient can, or the unit receives the result of the histopathology report. And in another facet is that in histopathology, we speak of quality control in the form of the normal laboratory procedures, like in all the laboratory, but we also have another branch, and that is the reporting itself, the technique of reporting. And this depends on the educational background and training of pathologists and on a lot of other factors. And another very important part of quality control is safety control in all its aspects. You have the physical, chemical, microbial, and of course also the instruments. In a diagrammatic form, the pre-analytical phase involves specimen collection, fixation, specimen transportation, specimen patient identification. Each and every point is a problem that where something can get lost. Specimen accessioning in the lab, and then adequacy of clinical history. In the analytical phase, we have the basic stations that the specimen undergoes: grossing, processing, embedding, cutting, staining, cover slipping, slide delivery, and diagnosis. In the post-analytical phase, we have report validation and completion, report delivery, and archiving of records, which is our data bank. Now, if we are aiming for a dependable histopathology report, we need to standardize our report. And standardization comes when we have something which led to the development of this collaborative organization, which is the International Collaboration on Cancer Report. And this is a non-profit organization which incorporated in 2014. It was developed to develop internationally standardized and evidence-based checklists for the pathology reporting of cancer. Now, with 12 sustaining members, it has representation in the 5 continents, and it has published 31 data sets, which are made freely available on this website. 13 additional ones are in development. So they are always more. Now, if the International Collaboration on Cancer Reporting, you can see it here in the middle. This is what produces or gives guidelines and data sets for the handling of all specimens that arrive in the lab. Let's now say tumor specimens that arrive in the lab. And the influence is definitely on, there is a clinical benefit, education, and for research and for population health. Now we'll discuss each of them, how they come about. In education, I can start here. We have the organizations, the CAP, the Royal College, the Royal College of Pathologists of Australasia, and then we have the International Academy of Pathology. They seek standardization, and CAP CAP and the Royal College have produced their data sets, but all of the data sets that have been available have been incorporated into the international collaboration on cancer reporting by the WHO. And you can see on their paper here, we have all of them represented. This is the Royal College. All of them are represented in these international collaboration. And this international cooperation depends on the TNM, tumor profiling, the AGCC. So all of them are incorporated together, which are all WHO, and they have produced this international collaboration for cancer report. The associations, the International Academy of Pathology with its divisions, and the pathological societies have realized the benefit of aligning pathology cancer dataset development internationally and started this collaboration. A standardized approach to reporting improves quality and completeness of a pathology cancer report. And use of standardized checklists enables pathologists to keep abreast of the latest information relevant to each cancer. Because the checklist and these standardized checklists are regularly updated with new knowledge from research. Protocols provide a means of achieving an international standard of pathology reporting without significant investment in countries, especially the low and middle class income ones, which lack the resources for their own cancer dataset development. In Sudan, we have been maybe by history, we were mostly going with the standards produced by the Royal College. But now in recent, maybe in the last 10, 20 years or 15 years, we have been more and more pushed towards the CAP, maybe because the Middle East or the Emirates and Saudi, they are using the CAP. And the younger generation of pathologists are more pushed to the CAP. Also, many of the researches that have started in Sudan, like cervical cancer research, all of them, after a lot of discussion, have adopted the CAP. So I think that instead of having to choose between one or the other, and in many cases, I was promoting the combination of the two, which is the data sets of the Royal College of Australasia. But I think it is good to go for an international collaboration since it's now available and everybody can take his input from that one and develop their own data sets. So let's see if this goes well. I want to go into the international collaboration for cancer reporting and show you the breast protocols. Now, is it still going well, and how is the sound? Now, this is the website for the International Collaboration on Cancer Reporting. And when I scroll down, you can see the published data sets. And we can go. And there you can see that for the breast, you can have ductal carcinoma in situ.
نادية ما ظاهرة في السكرين.
الويب سايت ما ظاهرة؟
ما ظاهرة في السكرين.
Because it's a shared screen, I thought it would go.
أرجع للشير.
If I do, because I'm screen sharing. I'm still sharing.
Sharing the presentation or the screen?
I'm sharing the screen.
Change the type of the screen. Go to the laptop. Change the screen من ده للويب سايت إذا أنت فتحت الويب سايت.
Oh, why doesn't it happen? Why, if I'm sharing my screen, why doesn't it show what I open? If you can see it, I will go into the breast. She's see? But this is Saturday. This is because it's Saturday. See now that I went into the data set?
Yes.
And it shows you that I have options. Even if I go into the breast, I have options. So I have ductal carcinoma in situ, variants of lobular carcinoma in situ, low-grade lesions, invasive carcinoma of breast, invasive carcinoma of the breast in the setting of neoadjuvant therapy, and surgically removed lymph nodes for breast tumors. So let me do this. I'll go into there again. Once I am inside the data sets for invasive carcinoma of the breast specimens, then I have also a scope because it gives me the data set as in words. It gives me as a PDF file, and one of them is, I will not open them because it takes so long. Maybe this smaller one. It's with a guideline of exactly what I need to do. Yeah, it's the net. Can you see it? Right. Yes, now you can see. I think, yes. Now, but this shows me that it's opening for them. No? So I'll leave it here. Now, this one shows you that the clinic, what is important. The important thing in this form, and it goes for every tumor you can imagine, you can have these data sets, and for the different types of operative specimens. Of course, always important the personal history, but the important thing in this form now, so we go back to the presentation, is that there are elements in black text, and these are important. These are the core. And then there are some elements in gray text which are non-core. And from this one, I can develop for my lab, for my setup, for my hospital or university hospital or whatever, I can develop a form that is for reporting, and it is for grossing of the specimen, and it will tell me, it will give me all the informations and allow me to share the data internationally, and I will cover everything that is needed in the report and that is needed for patient care. I'll give you an idea of how long it is. And we had problems in trying to publish something like this at Soba Hospital because of the amount involved in checklists are always better for information instead of writing a thesis. The typical report is now a thesis. It ends with pathological staging. Now let's go back to our PowerPoint. Okay, yeah. Now, I just wanted to show our point of view from our side. Sudan is a member of the International Association of Pathology, the Arab Division. The International Association of Pathology, we have the central one, the international. It has a meeting every 2 years, hosted by the different societies all around the world, by the different divisions. Sudan is a member of the International Association of Pathology, the Arab Division. And in 2012, the Sudanese Association of Pathology hosted the annual meeting of the IAP in Khartoum. Now on the 16th to the 19th of November, the 34th conference of the IAP will be hosted in Turkey. And it is sad because usually these conferences had a huge, at least, a huge attendance from Sudanese pathologists. The last one we attended after COVID was in Morocco, and Sudanese, they were quite a substantial number, had a big influence. The International Association of Pathology was hosted in 2018 by the Arab Division for the first time. It was in Jordan. And now just a few days ago on the 31st, ended the 35th International Association of Pathology Conference, which was held in Mexico this year. Hopefully we can join them again. I know for sure that Prof. Ajami will be there, and Sudanese pathologists that are able to travel. Now, another very important data collecting association for cancer is the International Association of Cancer Registries. And this one was founded in 1966 as a professional society dedicated to fostering the aims and activities of cancer registries worldwide. It is primarily for population-based registries, which collect information on the occurrence and outcome of cancer in defined population groups, usually the inhabitants of a city, region, or country. The association was created to foster the exchange of information between cancer registries internationally, so improving quality of data and comparability between registries. And standardized data sets for cancer are beneficial for surveillance and registry purposes. So once I have a standardized data set, it becomes much easier for cancer registries to function and to function nationally and internationally. For each cancer case, registries record details of individuals affected, the nature of the cancer, information on treatment, and on follow-up, especially with respect to survival from the disease. This used to be done as little cards in which each patient, just imagine the amount of work, because I've seen some of those cards. You write everything on cards, and these cards have to be sorted and kept in order. Now, of course, it is software produced by the association and available free to members of the association. We are now in the 5th edition of the cancer registry software. It's called CanRec 5. Open source tool to input, store, check, and analyze cancer registry data. And a short, I put in here this link for a short history of this organization for whoever is interested. Now, this organizations started as from the Global Initiative for Cancer Registry Development, and all of these are now involved in, we have the African Cancer Registry Network, the European Network of Cancer Registries, the North American Association. Each one has it, but all of them come together in the global initiative. And North Africa, we belong to the world is divided into 6 hubs. We belong to the North African, West and Asia, and it has a hub in the hub for this region is in Izmir, because in Izmir we have a cancer registry. The first population-based cancer registry in Turkey became the 2nd IARC regional hub for cancer registration within the, and it started in October 2013. This hub covers 29 countries and territories. We belong to the North African. I would love to go in again for this website, but I think if somebody is interested, you can do it. So because it takes time, and most of the information is in this slide. But we belong to the North African part, and you can see these are 29 countries. When you look through them, they go all across. Culturally, they are different, similar but different. And for example, in Western Asia, we have Bahrain included, and all these countries have become part of this in October 2013. This hub was produced, but we had the program started in '66. And some facts for Sudan: we have a cancer registry in Sudan, which was started and operated as a unit at the histopathology department at STAC Laboratories. If I remember right, it was started quite at the beginning in the late 60s, and it operated until the mid-1990s. A national cancer registry was initiated much later, and I think it was related to the 2013 decision to form the hubs. It was functioning. I say was functioning because now it's not. We staff recruiting data from histopathology laboratories all over Sudan. It was a huge effort that was run by people who totally believed in this idea. And just like things in Sudan, we're running things by force. For a time when I was at STAG Laboratories, we had Cancer Rec 4. Now we are in 5, but Cancer Rec 4 was installed in the reporting computers at our department at Stack Laboratories to facilitate. The idea was to, because at that time we didn't have so many laboratories. The histopathology department at Stack was doing a big load of the work in at least Khartoum. And the idea was to facilitate the input of cancer case reports to the Sudan National Cancer Registry by allowing the staff to do it directly when we are reporting in our computers. And now we have registries that are hospital-based, because that's the difference. We usually should base our cancer registries on population, but when it becomes difficult, we do them hospital-based, and these hospital-based registries are functioning at RIC and in what Madani, as much as I know. People can add information if they know better. But the nucleus of START was all the unit that was established by the Ministry of Health at the histopathology department at Stack Laboratories. Now to go back to our reporting of histopathology specimens, they depend very much on this little icon here. We call them the blue books. You can see they are here by the input and here. We depend on the blue books for the classification of tumors. And let me show you how this comes about. The WHO classification of tumors series are now in their 5th edition, which started in 2019, with an online version that started, but this classification of tumors started as blue hardcover books in 1956. The objective of the WHO classification of tumors is to provide a uniform nomenclature of human cancers that is accepted and used worldwide. A standardized classification is necessary for pathologists, clinical oncologists, and cancer registries. It forms a basis for collecting histologically and genetically stratified population-based incidence rates and is a prerequisite for comparing cancer therapy trials conducted in different centers and countries. The International Association for Research on Cancer assumed responsibility for the WHO Blue Books project as of the 3rd edition, before the 1st and 2nd editions were published by a German company, a publishing book, but the International Association for Research on Cancer then assumed responsibility for the books. Books are compiled by expert consensus, teams of who summarize information from literature. The terms included in books appear in the International Classification of Diseases for Tumors. They are published as a series of books, taking system by system or sometimes organ by organ, in addition to a website which provides information on cancer diagnosis, research, treatment, and outcomes, particularly for pathologists and cancer researchers. Now, diagrammatically is always better. The first row shows you the 5. This is the 1st edition, 2nd edition, 3rd edition, 4th, and this is the 5th series. This is a close-up of one of the volumes of the 1st series, the International Histological Classification of Tumors, number 9, because these are ovarian tumors. And this is how we had copies of these at the histopathology department in Stack, together with the Armed Forces books of histopathology. This one, I found this one for the breast, but the copy is not very good. Now let's go to the ones that we know and we're working with until today, and you can find them online. So the 3rd series for breast was pathology and genetics, tumors of the breast and female genital tract. the breast was included in the female genital tract, and the third series was this volume for the breast and female genital tract was in 2003. The fourth series, 2012, we have tumors of the breast. Then the fifth series, which started in 2019, we have just the WHO classification of tumors, breast tumors. So now we have, in the last two series, we have breast separate. And more now, especially in the fifth, it is becoming increasingly, of course, we have more now molecular classification, and now increasingly the books are becoming multidisciplinary. Each book defines the cause, the mechanism, the signs and symptoms, basic structure, diagnosis, epidemiology, and outcome of up to 300 types of tumor. Now in the fifth edition, some of the books have become 2 volumes, so that we have like in pediatric tumors, we have now 2 volumes. To 200 authors, including radiologists, surgeons, physicians, epidemiologists contribute to each book. This last point is a link to a very short article about the blue books in the pathologist. We come to another international classification of disease of oncology. The ICD, O is for oncology. In its 4th edition, will be produced next year, will come out next year, 2025. This is a classification of disease because in the WHO we have the international classification of diseases, and this one with the dash is for oncology. And it depends on the histology and the behavior. It gives a guide for histology and behavior. And a numerical code is given for every type of cancer, depending also on topography, where in the body the tumor occurs. Therefore, because of the amount of data, we regularly need to follow updates in classification of tumor. The ICD-04 classification has a new morphology structure with 5-digit morphology code. This is the new additions in the 4. Now, let me show you 3 for the breast. The C50.1 is a code that I give when the lesion is in the nipple. And like 50.1 is the center portion of the breast. So you give a numerical value according to the topography. Upper inner quadrant of the breast is 50.2, C 50.2. Each and every area in the body has a different code. Then the other, for example, the ductal and lobular neoplasms are in the range of numbers 850 to 854. So for example, I'm now just quoting examples in the next few lines. You have infiltrating ductal carcinoma, NOS, C50, and then I have to put the code for where in the breast it is, the number in the dash there. But 8,500, it's a 4-digit code, /3 gives you a guide, or this is the code for the behavior of the tumor. The first number, 8500, is for morphology, /3 is for the code. 0 is benign. You can see at the last line in the presentation, in this slide. Number 1 is uncertain, so definitely will not have it here because we are talking about cancer. and carcinoma in situ is 2, like intraductal carcinoma and lobular carcinoma in situ. C50 means it's in the breast. This we know for sure, but here you can put code for where in the breast it is, and then its number is 8,522. For example, intraductal papillomas. Papilloma is a benign lesion, that's why it is 0 for behavior. Medullary carcinoma NOS is 8,510 and 3 because it is malignant in its primary site. So this is this one is not the complete one, of course, because we have so many pathological, different pathological lesions in the breast. And this is just an example to show you if I have a medullary carcinoma, I can open the cancer registry page and put in the code. For example, if I put in the code 8510/3 and put the C50, C50 with the area in the breast where it is, I can add, put this into a system of the cancer registry, and it is registered as a numerical value that can be better analyzed. And if I'm looking in the cancer registry for a certain type of cancer, I can put in the code and get all the cases. So the numerical value helps very much, but I need to update the numerical value because these numerical values that I'm using have to be expanded every time whenever I have a new classification or I have additions to my classifications according to the Blue Books. Now let's finally come to our histopathology report. A surgical pathology report is a medical report that describes the characteristics of a tissue specimen that is taken from a patient. The pathology report is written by a doctor who has special training in pathology, so-called histopathologist. A pathology report includes identifying information, such as the patient name, birth date, and biopsy date, whatever identifies my patient. In Sudan, we use, of course, 4 names because it makes life easier. And the details about where in the body the specimen is from and how it was obtained. So the specimen type. If it typically includes a gross description, the macroscopic findings, a microscopic description, and a final diagnosis. It may also include a section for comments by pathologists. The diagnosis section of a pathology report is the pathologist's summary of all the findings of their macroscopic and microscopic examination of tissue specimen in combination with relevant clinical information. The cancer type will be identified, including the tumor grade, lymph node status, margin status, and pathological stage. Pathology report provides the definitive cancer diagnosis and is used for staging and plan treatment. The breast specimen histopathology request form must include the requesting clinical unit or practitioner. We use this so much to get more information. As long as we don't have established breast clinics, this is our means of getting medical information from the team that has been treating the patient. And of course, we also depend a lot on the co-patients. Patient demographics, relevant clinical history and previous investigations, including histopathology reports, the type of biopsy, site and time with number of containers all labeled, test requested. It might be strange to ask for the test requested, but it should be stated by the requesting unit that they want this specimen for histopathology or for whatever they want it for, or maybe in histopathology, a certain part of histopathology, and how urgent the report is. And it's not that we write on every form urgent, or histopathology reports, I should say, are urgent because the patient is waiting, but urgency and the degree of urgency can vary according to the biopsy taken. This is sort of what we have been talking about. You have the personal history at the start to identify the patient, the requesting physician, clinical information, then the site of biopsy, the position of the lesion, distance from the nipple, image finding, sonographic findings, intraoperatively, what happened. Sometimes we needed intraoperative consultation, specimen type, which type of specimen was sent to the lab, the number of the specimens, especially if they are, even if they are, ideally they should be in different containers, but if lymph nodes are taken separately, if they're, but each one should be labeled. Orientation of the specimen, time of surgical removal of the specimen, and when it was placed informally, preferably should be the same time. Now, the type of specimens, the technique employed can tell me which type of specimen it is. For example, a true cut needle biopsy, which is usually guided, we are naming it according to the equipment or the technique used. We can have incisional biopsies, and sometimes they are wedge biopsies or open biopsies. Excisional biopsies, one of the mass or mastectomy, partial or total. Resection of margins, so sometimes we just have a re-resection of the margin. Axillary tissue biopsy, and according to the biopsy taken, you can name it. The clinical timing of sampling, was it intraoperative or extraoperative? Sample location, purpose of the biopsy. Is it diagnosis? Is it a diagnostic biopsy? Is it to respond to therapy or treatment? Is it an experimental biopsy? Processing of the sample. Sometimes the sample is taken, and like when we need the frozen section, the intraoperative consultation, we need a frozen section. So this has a whole other processing because we need to do it, sort of drop everything and do it, because it should be arranged beforehand. And there is a certain protocol that is followed. In Sudan, I would, the best thing would be to have the frozen section microtome actually in the theater, and we would attend and have a microscope and read it there. Maybe that's the best thing because of transport. Embedded in the normal processing, the routine processing for light microscopy is embedding in paraffin for H&E sections. And this is our usual routine, but it could also be for electron microscopy. And then the fixative is not the same one. It needs to be different. Sometimes we need fresh samples for immunofluorescence studies and for microbiology. And in that case, the specimen is fresh. It needs to be protected, but not fixed in formalin, and it needs to be rushed to the lab. The sample might be taken for molecular analysis to detect specific genetic anomalies. So according to what the sample is needed for, preparation for the laboratory is different. Now let's go into routine. The routine is we need to preserve the specimen and transport to the lab. And the routine handling for histopathology diagnosis is to use 10% buffered formalin at a ratio of tissue to fixative volume of 1 to 10. And fixation time depends on the rate of penetration into the tissue. But in all cases, it's always good for a quick transport to the laboratory. And maybe during a theater, the day of a theater, it is good to arrange for transport at multiple times to the day, during the day. And this defeats all purposes, of course, if, like in our situation, actually the patient is given the sample, the co-patient is given the sample to take to the lab. And it's one of my headaches in Sudan. As soon as possible, we like the specimen to come to the lab because handling starts then very early. And another point, which is in the pre-analytical phase, because it happens in the theater, is that we want to avoid cold ischemia damage. And cold ischemia damage, or cold ischemia, is the time when the tissue is taken from the body, so it has no more blood supply, until the time it is placed in adequate and appropriate formalin or fixative. And sometimes in the theater, we get involved because we realize that the specimens arrive in a less than ideal situation. And we realize that either the formalin in the theater is not appropriate, and we check that, or the theater does not prepare the formalin before the operation in an adequate container, so that immediately when the tissue is removed, it is placed in formalin. They sometimes put it into a kidney dish or into even core biopsies. They put the specimen into whatever container in the lab, and then later put them in formalin. And this lengthens the cold ischemia damage that happens to the tissue, and we can see it when we finally process the sample. But prompt, careful handling of tissue in general without pressing or crushing, and prompt appropriate fixation enables a confident histological diagnosis and ensures accurate immunohistochemical results, especially in the case of the breast for ER, PR, and all the immune markers. Specimen identification and registration, the first step that happens in the lab. And we should reject specimens that don't have clear label. You can see here a specimen in adequate amount, like a breast mastectomy, and second container, smaller one for the lymph nodes that were removed, or the centennial lymph node that was removed, or another lesion that was found in the breast. But usually this is the specimen that arrives in the lab. And in the open container, you can see core biopsies in formalin. They are usually in adequate formalin. The problem is that they should be immediately put in formalin and not first in saline, as sometimes happens. Whatever they are using in the lab. Standard histopathological techniques originated in 1860s in Germany, and were a consequence in the development of optics, so with microscopy and being able to look at tissue. but it needed to be tissue needed to be processed once we had the microscopy, that they are thin and light can pass through them. And that's the whole idea, is to produce thin sections of tissues and impart sufficient contrast by staining to enable differentiation of different cells and their components. Now, the process to do this is still very much the same, although it has been influenced again by development. But as I go along, I will tell you what type of development has happened, but these stages are still the same. So it is fixation, and this is a part where we are not involved, but we get ourselves involved in the theater and we ensure that they have. And I can do this in a hospital setup, not when I'm receiving specimens from all over. Processing, embedding, sectioning, and staining. And processing stages are composed of dehydration, clearing, and impregnation. And now in diagrams, we'll go through these. Formalin, because this is the first step in processing of a specimen. A fixative prevents postmortem changes, which are autolysis and putrefaction, and conserves morphology and chemical characteristics of cells and tissues. And we use those to identify the tissue. Now, 10% neutral buffered formalin, 10 times the specimen volume, which is usually never kept. And the slices to allow the tissue to become fixed, the ideal thing is to slice the tissue, because even if in the theater, like the core biopsies, they are put into formalin, well and good, I don't need to do anything. But if I put an excisional biopsy or a mastectomy into formalin, even if it's 10 times the volume of formalin, it will not get fixed properly, because I need to slice the tissue, preferably into 0.5 centimeters tissue slices, and get the formalin to move into the tissue and cause the fixation. Now, different tissues take longer or become quicker fixed. Room temperature is important. Sometimes agitation can help, but we don't use that. In Sudan, we don't have a problem with room temperature. We need to open specimens. We say open specimens when they come to the lab, because they need to have half a centimeter thickness, so that 8 hours is a very long time. So usually it's 4 hours. For the breast, we leave them overnight. Cross links are formed between amino acids, making them insoluble. The thing is that formalin is available and cheap, but it is an irritant to mucous membranes. And this is one of the problems in the histopathology department. And although many other fixatives have been produced, but still formalin is one of the most common, and I think it will stay some time still. Now, grossing room. This is the room where we cut up the specimens. It should be well illuminated and ventilated. Grossing instruments and board. We need a good grossing instruments. Disposable supplies of pencils, cassettes, ink, acid for decalcification, gauze, cotton, and scalpel. Plates, running water and waste disposal. This should always be arranged, because in these cases, the waste includes body fluids, and so the and you have fragments that go into the running water. So usually you have like in modern kitchens, you have something to open drains and sieves and areas to clean it. So as you can see in this photo, you have beautiful crossing sections, stations. But you can imagine, you can go from scale of 0 until up to the most expensive ones. The important is to have good light, to have good instruments, and to have an area finally for specimen shelves to keep the specimens. Usually we keep the specimens in modern labs. Usually specimens are kept. Once you issue the report, you can dispose of the specimen. In our setup, we used to keep specimens for up to 3 months minimum. More views of grossing stations. In here you can see what we call cassettes. When I said the reagents that we need in the lab, one of them is this important thing, because this has a roughened edge here where we can write the number that the specimen receives in the lab. So, because this is one of the important points, we are opening the labeled container of specimen, taking a sample of that, it belongs to this patient. So this is the first step where we can get mix-ups. We open one specimen and we have to make very sure that the number that was given in the lab to the specimen has to be written in this roughened area. And we use pencil, and pencil does not is not affected by the processing of the sample. So another photo for grossing. You can see you have all the material. You have the material, you're cutting small sections of it and filling this one and covering it with a plastic cover. The most important thing is here is a transfer from the specimen container to our cassettes. So what do we do in the grossing room? We identify the specimen. We again identify and compare with the request form to make sure that this specimen belongs to the request form that came attached to it. Again, we verify, we orient our specimen. We make sure that the specimen is placed and we coordinate with what the surgeon has removed. We measure and weigh the specimen. We describe the specimen and we document it either in descriptive form or by taking photographs. We ink the margins. We used India ink, and now in the market we have so many different types of inks. It used to be just black. India ink is black, but now we have so many different colors, and you can practically for each margin make your lab policies that for each margin of the oriented mastectomy we can use a different color. But the thing is that all these now commercially available inks are not removed by the processing that happens afterwards. We then slice and open, and then we slice and open and take our samples. Once you slice the specimen open, you describe and measure whatever tumor is there. Then we take our sample and we place them in the labeled cassettes, making sure that. So you can imagine that in grossing room, usually we don't like disruptions at all, because it's an important step of preparing the slides on which you do your diagnosis. Another grossing station. The yellow bucket is for sharp objects. Usually we can have linear flow in these cabinets, so the irritant smells of formalin are avoided. You can harvest. Also drainage of the of the fluids can go through a suction apparatus, and then here we can have recording of the gross, which later the secretarial staff will type out as macroscopic description. We can have computer programs that help us in doing measurements. There are many available in the market now. You just make a photo of you get your digital scanning of the specimen, and you can do all the measurements by so many in the market now, computer systems that help you in measurement. The important thing to do it at ease because looking for lymph nodes is not easy. Slicing the tissue and examining each slice carefully to see whatever lesion and comparing it with the information that we have from imaging and from clinical. Now, these are two specimens. One is a lumpectomy and the other is a mastectomy. And usually for orientation, we have, by consensus, we agree that a long stitch is placed on the lateral border and a short stitch is placed at the superior margin, so we can orient the specimen. In mastectomies, of course, the attached axillary tail can help us. The lesion that was excised in mastectomies also helps us in orientation because we are supposed to get the site and wherever it is. And if it's multiple lesions, this is the slicing that should happen once the specimen arrives in the lab. We ink the deep, like in this case, this mastectomy, we have inking of the deep margin and slicing, and then we place gauze or cotton in between the slides, in between these slices, and put it back into formalin, and then we come usually next day or the day after to do the grossing because we want to ensure that the tissue is fixed. Once the tissue is fixed, we cut the slices. The slices that we have opened, we cut them and lay them out, numbered, and then we can describe exactly where the tumor is and take our blocks. Take our samples for processing these are called blocks. And this is what we are aiming. We get the specimen in A, which is not fixed. So the description, the first description, we slice it open, we leave it for fixation. The cut surface in B shows the tumor, and in C, that tumor is in a section, which can be then reported. Another example, and in this one you can see in A the fresh specimen, in the second one where the tumor has been inked with different colors after orienting it. Usually the lab says that if you have different colors, you can say that in our lab, the superior margin is always blue, the inferior margin is always red, and the lateral margin is yellow, the deep margin is black. You can put your protocols and then when you look at the section, you know for sure. And the different slices of that tissue, once it's fixed and you make your slides. So in D, you can see the completed, prepared slides for histopathology and the correlation to where they were taken. A mastectomy, still soft. They have opened it and ink, and it's now after you take it out, you ink, and then you start taking your sections. And You can identify where the tumor is by, of course, correlating with clinical information and imaging, but at the same time, by palpation of the slices. Another example. In this case, the deep margin is blue. Slicing, inking, and documentation. You can make photographs of the slides that were prepared of the specimen to go back to later and to show from where your samples for processing were taken. Tissue to be submitted for mastectomy. You do 4 sections of the tumor as a minimum, with adjacent breast parenchyma, nipple and areola, skin overlying the tumor, deep margin of the base, any suspicious gray-white area, axillary lymph nodes, and level 3 lymph nodes from the apex whenever available. And this is like a rough guide where you should take your blocks. The labs prepare their guidelines for mastectomies, for the different types of mastectomies. But usually, in the end, you need to do according to the clinical case. You never just stick, if I say 4 for a tumor, okay, there are some tumors where I need to take 6, where I need to take 10. So it depends on case by case. All grossing information blocks taken are recorded in a working sheet. We write that in, you can see here very clearly that you have the number of the lab number, and we give each block a number of itself. For example, if this is case number, let's say lab number 8, I can't read it very well, but it is like here, 435. So 435 is the lab number for this patient. And then we give an extra number because each of these blocks needs an extra number for which number from this case it is. So we either go A, B, C, or we go 1, 2, 3. And then we write on our working sheet in the lab, we write that block number 1 is from the nipple. Block number 2 to 4 is from the tumor. It's according to how we have the protocol in the lab. In my case, I used to take block number 1 was always the nipple. Then I used to take from the tumor and then from the margins and eventually the lymph nodes going from the level 1 according to how many lymph nodes arrived. Sometimes the lymph nodes come separately and I can give the mastectomy specimen an A, so it is A1, A2, A3, and then I go to the lymph nodes and they are B because the specimen is called, for example, 435B, but then the blocks will be 435B1, B2, B3, and these are for the lymph nodes. You can see that blocks for tinier pieces of tissue can have a finer sieve system, like here for the cores. And usually cores are placed, it's more important in prostate biopsies where we get up to 12 cores and even more. So not more than 3 in one cassette. The cassettes have, you can see here, they can have different colors. They're important in a lab because, for example, my lab policy could be that all core biopsies, breast or any core biopsy should be in pink ones, and the pink ones should be run quicker because they need the report quicker. And it could be lab policy as it goes. But this photo I got also because it shows you the cover. And here the cover is separate. Sometimes they sell it separately. Sometimes they are just hooked onto them like that and you clip them close. And they don't open because if this opens while I'm processing the tissue, I have a problem. Another thing that could help in the selection of tissue for processing is the comparison after I take the block, or once I have the tissue in the lab, I can do scanning of the tissue and to make sure that I have received the lesion that was sent to me. With our modern techniques and screening, we are finding smaller and smaller lesions. In the end, specimen sampling depends on good clinical judgment on a case-by-case basis. So I can have a mastectomy where I take up to 30 blocks. It depends on the clinical case by case. Now, what happens next is processing. And in processing, I'm taking tissue, the fixed tissue, and I want to prepare it for sectioning by microtome to do those thin sections. And to do that, I need to dehydrate. Tissue is mostly water, so I dehydrate it by alcohol. I replace the alcohol by xylene. And finally, I replace the xylene by paraffin wax, because I cannot replace water with paraffin. I need a step in between, and xylene is the perfect step in between. Lots of talk about xylene, but it is still one of the, it is still used extensively, although we have alternatives that are processing xylene free, and because there is talk about xylene, it's carcinogenic and it has many effects. But still, this is the classical way, and it's continuing. So the first step is replace water in the cells with alcohol. And usually we do it stepwise. We don't do it one go. Then xylene dissolves out the alcohol as a middle step, and then paraffin replaces xylene. And once I have a paraffin embedded tissue, it is firm enough so that I can do the thin sections. Another diagrammatic form of these processing steps, the dehydration, I do it in steps. I do 70% ethanol, 90%, 100%, 100%, 100%. Then I do xylene again in steps. So this is just to clarify the background of processing steps. Now we are coming to what it looks like actually. The schematic diagram showing the time schedule of overnight processing. We do the dehydration phase, then we do the clearing. That's when xylene is involved. Then we do embedding, where we have paraffin going into the tissues. And this is what it looks like in the lab. We have so many machines of these, but basically the principle is all the same. We have, you can see this. This is the most common one we see in Sudan. And you can see when in these two photographs, you can see how the basket moves from one beaker with the different reagents, from one beaker to the next by just coming up, moving to the next beaker. These are usually where we have the paraffin because it needs to be molten. So these have a heating system involved. This is the same, except that it is, instead of being in a round shape like this, it is straight. And this is like a bigger center of hospital where you can have more than one batch running through. In these you have one batch usually, but in this one you have one batch started now, and you can put in the second batch. So these process up to over 300 and more specimens. This basket usually takes about, it depends on the size of the basket, but it can take up to 80 blocks. And some of the machines have double baskets. So you have one basket here and one basket here. Basically, the principle is all the same. You can also do it manually, of course, having beakers of the reagents and moving every 1 hour. The good thing is that in automated processors, you have the tissue moving automatically by hydraulic mechanism from one jar to the next according to a fixed schedule set in the processor program. Generally 1.5 hour durations given for each station, and the whole takes 18 hours. So that's why usually these processing usually takes overnight. When indicated, rapid processing can be completed in 2 to 3 hours, ensuring quicker reporting usually for small biopsies. And beautiful system that depends on vacuum and on microwave can shorten the system and give you reports, report capability to report during the daily routine. For example, specimens that are received early in the morning can be processed and the report written at the end of the day. And this is usually done for small biopsies like endoscopic biopsies of tumors from the gastrointestinal tract. Can do it for core biopsies, and it makes what we call day reporting. Now, once the tissue is removed from the processor, it needs to be embedded. And the tissue is already embedded in wax, but we need to embed it in a block of wax. So we open the cassettes, and you can see here that the cassette was opened, and this is another very important step, because embedding needs to be done carefully, because we are removing from the cassette, we are removing the tissue. Remember, this cassette has the label. We are removing the tissue, putting it in a mold, and this area is heated so that when from the dispenser here, we are pouring wax over this tissue in a mold. After we place them, and we have to orient them according to the tissue, we take this same cassette from which it was removed and place it on top. And it looks like this. This is the empty molds. It looks like this, and we have orientation of the tissue. In other specimens as well, for example, tubular structures, we need to put it into the tissue that when we cut a section, we want all the layers to be seen. For example, in the intestine, we want all the layers to be seen. If you have a membranous structure, we sort of roll it up. And if we have like endometrial curettings, we try to keep them in the center. If I have skin, I have to put it in the right way. From the grossing room, I have to cut the section right, and then also in the embedding, it has to be right. These are different types of cassettes that are being used, and you can see very clearly that there is a label here. While we are putting the molten wax onto the embedded tissue, you can see here, this is a hot plate, this is a cold plate. Once you want to fix the tissue so that you can pour the molten wax, you have to put it on the cold plate. Core biopsies. You can see the stages here. You have a mold, you place the core biopsies that have been processed into the mold, then you place the labeled cassette from which you have removed it. You place it on top of the mold, put it on the cold plate, and then when you take it out of the mold, it looks like this. It's ready for the microtome. And this is the instrument used to cut serial sections from the prepared paraffin block of formalin fixed tissue. So that's where you get the abbreviation, formalin fixed paraffin embedded block. The most commonly used type is a rotatory microtome, where the tissue block is fixed to a holder and moves up and down on a stationary stainless steel knife. Or now we have the replaceable, the disposable knives. Due to the friction heat, the cut sections form a ribbon, which is transferred to a water bath to allow the section to completely unfold and be picked up onto a glass slide. The sections are usually 3 to 5 micrometer in thickness. Before staining, the slides are dewaxed in an oven. So let's show you the diagram. This is the ribbon I'm talking about. This is a microtome. The technologist, by the way, all the steps in the lab are done by a technologist. Starting, they receive from the grossing room, they receive the blocks that we have prepared or the sections that we have taken. They go into the main lab and they are processed by technologists. Here, the technologist is rotating to move this is the block that we have prepared. It is fixed to the microtome. And then by rotating, this goes up and down against the knife and the sections are cut. It's a technique that they learn and they are very good at it and gives you very beautiful sections. Now here you can see multiple sections of the block, each one showing the 2 cores. You can see these are cores. They are floated out on a water bath. This is the water bath, and then picked up by the slide. And here with this instrument, she's just removing them. And this way you can pick up more than one section on one slide. You have the block fixed to the microtome. Here she is using, you can see her hand here, she's moving it up and down to do the ribbon, then pulling out the ribbon, transferring it to the water bath to float out, and then picking it up on the section. And you can see this is a thin layer of wax, and you have the tissue heap. Now these slides are put into a rack, and of course here we are doing the labeling again. These slides are put into a rack and they have to go to the oven, and we remove the wax by heat. Different types of microtomes. The microtomes are now, as I said, the rotatory is the most commonly used. We have another one called the rocking one, where it's the block moves, the knife moves instead of the block. Then we have, they are becoming motorized so that you can set the speed and the technologist doesn't need to move the block up and down. It's done by a motor, but in the end, it's the same process. Our routine staining is hematoxylin eosine. It can be done manually. It can be done by machines, and in some cases, special stains are requested. Sometimes special stains are directly produced by the lab with the H&E sections. So because in some cases you need you have a protocol that special stain, certain special stains like in renal biopsies, we never read the H&E only. We read H&E, PS, Salwa al-Hakim, PS, and anyway, there are 4 stains that we need to read
Silver
together.
stain.
تتكلمي معايا نادية؟
نسيت.
قلتي شنو؟
renal biopsies. We always have 4 stains. We have H&E, PS, silver stain, and
Mason trichrome.
Mason trichrome.
Sometimes we add more like congruent, if necessary.
But this, I mean, that the lab, when it prepares the renal biopsy, it never prepares only H&E, because I cannot read it only on H&E.
Yeah.
And this is the preliminary for renal biopsy, because eventually it has to go to other things as well, like
these are mandatory.
These are mandatory. Then you go to electron microscopy and things like that, because this finishes off the renal biopsy. So each has its own. But like in breast, for example, we start with H&E. So this is what the lab needs to supply us to read. But then later we can ask for special stains. Sometimes we ask for congruent for amyloid, we can ask for immune stains for myopsylia layers, and of course for the markers eventually. So
also, Nadia, special stains like for mucin, for example, for H. pylori, and all these things.
Yeah. So we call them special stains, but I always say it's special routine stains. And then we have the special stains, like you have special stains for certain muscle diseases and things like that. Anyway, the staining, as we said, can be manual or automated. And then we cover the section, this thin section that is on the slide that has been stained, and you can see now it's looking more like it. Then we put a cover glass on top of it to protect. And it can stay for practically for as long as the type of stain is right and of good quality, it can stay forever. Now, another important point is at the end, you have all these batches of blocks that have been processed. As I said, you have the basket takes about 80 blocks. If you have full both of them, this is 160 slides in one go that the lab will produce. And then in the end, after you can see they are nicely labeled. Then you have to sort them, because you have your working sheet, you know that case, the mastectomy case with that number had so many slides and all the numbers are right. You have to put them in order and sort them. And very often now they are scanned and you get the slides. Actually, you can have a diagnosing pathologist who is sitting somewhere else and will look at his screen and open a digital folder for the cases instead of having the glass slides. And he can diagnose the case from there. A lot of digitalization is being done and we call it scanning. So the new step for technologists in the lab is now to scan after sorting the slide, doing the scanning to have these digital images. Reporting. Oh, I didn't change this. Pathologists classify and diagnose disease based upon the morphologic changes induced by cell and cell injury. This is basically true, but for today we are talking about tumors. This is the typical report as it used to be, writing the pathology report, and the purpose is to communicate all the diagnostic, and predictive findings. Now, the report that we produced until we stopped now was similar to this one, and people, I think, in Somalia are still continuing doing this, and in Port Sudan. So it's a typical report that you have been seeing. I have showed you the checklist at the beginning, and I think we should move on to that one. Hopefully, once we are back, we can do that. So typically it should establish or exclude the diagnosis of invasive breast carcinoma and or carcinoma in situ, specify the presence of lobular neoplasia, report the prognostic factors in the presence of a malignancy such as histological subtype, tumor size, histological grade, lymph node status, and lymphovascular space invasion, specify the status of the surgical margin and the distance of the tumor from every margin of surgical excision if reporting for surgeon excised specimen. If DCIS is present, mention the size or extent, cytonuclear grade, gross pattern, extent of comedonal necrosis, skin involvement, Paget's disease, surgical margin status, presence of associated microcalcifications, and presence of extensive introductory component. Report the pathological stage. Tumor size, we give the notation of P to report that this is the pathological stage. The status of metastasis to lymph nodes. Then by immunohistochemistry, we give the hormonal prognostic. Now, as a last part in this lecture, I would like to go into grade. Stage, I think is clear. We do the tumor size and the pathological tumor size and the pathological lymph node status by counting lymph nodes and showing the type of deposits that you have in the lymph nodes. But grading is purely pathological, and usually the Nottingham combined histological grading system, which depends on the Elston-Ellis modification of the Scarf-Bloom-Richardson grading system, is the most commonly used for reporting. The grade is determined by assessing three morphological features: the amount in the tumor, the amount of tubule formation, the extent of nuclear pleomorphism, and the calibrated mitotic count. We say calibrated because it depends on the field of vision that we have in the microscope that we are using, and there are tables that show you the field area involved, and according to the microscope you have. If more than 75% of the tumor shows tubule formation or gland formation, that's a score of 1. And moderate degree is 10 to 75. You can see that's a wide range. That gives you a 2 in a score of tubule formation. A little or none, which is less than 10, then it's a 3. Nuclear pleomorphism, we have small regular uniform cells, that's a 1. So anything that looks almost normal. Then we have moderate increase in size and variability is a 2. Marked variation is a 3. And in the mitotic counts, it goes from 0 to 9 is 1, 10 to 19 is 2, and more than 20 is 3. I'll show you this more in this diagram. Tubule formation, nuclear pleomorphism, mitotic count. Once I have this for a tumor, for example, in a tumor, the usual is that you can between 10 to 75% tubule formation. This gives you a score of 2. The nuclear pleomorphism is moderate. Then you have a mitotic count of more than like 10 or 12 per 10 high power field. That's what you usually do. We count these mitotic counts per 10 high power fields. So this would get, when we add this together, 2 plus 2 plus 2, that's a 6. And that would put us into a final score of 6, which is a grade 2 tumor. Tubule formation in diagrammatic form, and I took this from a nice blog that I found. I give you the link at the bottom. In diagrammatic form or in section forms, you can, I think, very clearly see here the variability. The thing is that 2 points, and this is very common. And you see most of our tumors are like this, although we have a lot of these as well, but mostly it is here. How this is like nuclear pleomorphism is how ugly the tumor is. Once you have these bizarre forms, it's, of course, whenever you are using or emphasizing a point, you are using the very clear ones. And you have to take this for like all over the tumor, because if I have 4, 5, 6 blocks of the tumor. I look at all of them and I look at worst areas. Mitotic counts, always, as we said, per 10 high power fields. So I count 10 high power fields and I make and I see what number I reach. How many mitotic figures I see. Like once it's abundant, you can see in one high power field, I'm seeing 3 already. And you put those together. So well differentiated low grade, 3 to 5, 6 to 7, or 8 to 9, because the maximum is a 9. I think in conclusion, it's teamwork. We need to depend on the information that comes from the medical facility you are working in, not only in that what happens in the theater and how the specimen arrives, but in setting up the whole laboratory system and allowing you to do what you think is a minimum to have a dependable report. Then a well-functioning laboratory team, of course. You can see that the specimen, once it arrives in the lab, it starts getting handled from or in such a way that you're taking it from the specimen containing, putting it on grossing, then later, then you open it. When you receive it, you put it back in its container. It has to stay in the lab in a well-preserved area. Next day or 2 days later, you open the mastectomy and you start looking and describing it, and you want to take even more details about it. And then sometimes we even go in these 2 days and collect more information about the case because we couldn't understand it. Go back to the surgeons, go back to the radiologists, go back to the co-patients and ask them because we saw something strange in the breast or we don't have enough information on the request form. Then you work on the taking the specimen and you take it to the lab. So the laboratory team must be in concordance and all the time realize where things can go wrong. Multidisciplinary team. If I have the information from a multidisciplinary team, it makes life easier. It tells me where I can take back the information that I have got. It makes all the difference for the patient who needs a treatment. These are all the references, especially to the websites that I have quoted. And the last two shows you a breast grossing video on YouTube. And the last one shows you lab stations of a specimen. And this is usually in a very busy lab, so don't be surprised, but it shows you how a frozen section is done, and it needs to be done quickly, and it's usually read within 20 minutes to report back to the surgeon who has a patient on table. Thank you. One last point on the 6th of November is, again, like every year, International Pathology Day. Thank you. Any questions or comments?
السلام عليكم يا دكتورة نادية. ما سؤال بس دار أسلم عليك ومبسوط.
أهلا وسهلا.
عبد الله جابر، كيف أخبارك؟
أهلا وسهلا، كيفك؟ إن شاء الله كويس. So good. I enjoyed this because I could hear your voice زي المرة اللي فاتت برضو.
أيوة حياك الله، يديك العافية. to see you again وأشوفك وكذا.
Hopefully next time in person.
معانا. الله يعطيك العافية إن شاء الله.
إن شاء الله. الله يغطي على البلد دي.
Okay, thank you, Nadia, for remembering all what we were doing for so many years. Yeah. So the memories we were working together in Stack and in Soba for many years.
Yeah, and I remember, Selva, when we prepared from our textbook of pathology, basic textbook of pathology Ackerman for Stack at Stack Laboratories, we prepared before all these guidelines were available, and we didn't want to have extensive ones. So from our textbook at the back of this Ackerman surgical pathology, we have grossing guidelines, and we prepared them for Stack and Soba.
Yeah. And we prepared the reporting format for so many things.
Yeah.
Just for the audience, I would like to highlight on the problem where we were facing with the fixation of the specimen. Yeah. This is one of the biggest problems. Putting in mind that the ischemic time, we don't know what is happening in the theater. No. Some of the physicians or the surgeons, they put the specimens it's supposed to be put in formalin immediately after removal of the specimen. Whether lumpectomy or mastectomy or whatever, it has to be put immediately so that to shorten the ischemic time, because the ischemic time is start from zero from
removal
when the surgeon start of the specimen. Exactly. And to minimize this is a specimen has to be put in formalin immediately, buffered formalin, and the amount has to be adequate in a ratio of 1:9. 1 volume for the specimen and 9 volumes for formalin. And these are the things we're facing, especially when specimens, when the operation was done in the weekend. For example, in Thursday, it will be with the patient for Friday, Saturday till Sunday. By this time, already autolytic changes has been started, and there is a problem with hormonal, doing ER, PR, HER2, and even the grading
even
of the tumor itself.
Yes, even the grading.
Yes, even the grading is a problem. This one thing has to be highlighted. It's important. Fixation and putting the specimen in the right container. This is the most important thing. And I think you highlight the data sets, and all these sets of reporting, they are really good by reminding the pathologist not to miss any information, because these information are important for the treatment and for the prognosis and what the oncologist will do at the end for the patient. And this is important for documentation even. And especially when we have resection or recurrence of the tumor, and so that we can go back to the information before and see what has happened. This one of the important things to be done.
Yeah, definitely. It's one of the headaches.
السلام عليكم.
Yeah.
السلام عليكم.
دكتورة آمنة.
وعليكم السلام.
كيفكم؟ تمام. ازيك دكتورة سلوى؟ ازيك دكتورة نادية؟ أنا آمنة. فضل.
آمنة أخبارك؟ آمنة أخبارك؟ وينك مختفية؟ سنين
كيفكم؟
مختفية. كيف أخبارك؟ تمام؟
إن شاء الله كويسين الحمد لله. كيفكم انتم؟ يعني أنا سعيدة جدا، فرحانة الليلة بالموضوع ده شديد.
والله نحن أسعد. أيوة.
كانت من البداية إنه how to write a protocol or guidelines for the reporting of the mastectomy or for breast cancer. وكان في الأول إنه ما بين الكاب وما بين الرويال كوليدج، إنه هل دي بتعتمد إحنا لو جينا في السودان عايزين نعملها، هل بنعمل مثلا a combination or combination between two ولا إحنا لازم نعتمد واحد فيهم؟ يعني هل إحنا Africans نعتمد الرويال ولا إحنا تبع العرب نعتبر الكاب؟ يعني حتى لو في السودان عايزين نعمل standardization للريبورتينج، فدي كيف بتتعمل؟ إحنا ممكن نعمل حقنا برانا، الناس تعمل براها وتعمل combination
Yes.
between الاثنين.
Yes, Amna, we can. This is why I didn't go into the details as we usually do of the Royal College or the CAP or the Euro-Asian. By the way, I was for the Asian, the Australo-Asian have a combination of the two, by the way. But if I have the international collaboration, I can use that one because it was made out of all the others. I do not need all the details. I have the link inside. You can take a look at them. We can adapt, and we must make sure that at least the core elements are inside.
Yes. So it should be. I think it should be for standardized for the all hospital, even private or public hospital, I think. And هسه now بعض المناطق ما زالت شغالة، يعني مثلا الشمالية مثلا من منطقة شندي ودونغولا they have a different reports. They have a different reports, and I think it should be standardized. I know that the situation and الحرب وكده like
أمنا نحن when let me tell you, in the end we were starting in Khartoum. The thing is in Khartoum and most of people working in Khartoum and outside Khartoum are produced in the same colleges and from the same institutions in Sudan, even if you consider the others. The thing is, you need to put down to make it official that this is now a national or this is what we follow in Sudan. You cannot expect people to follow something that's not like a rule.
Yes.
Now, the easy thing is that people are coming from the same institutions, but to follow the rule, if they come from outside, they're used to it. But if everybody, you need to have something that you decide on, and you say now all reports must be issued like this. So this is it's not such a problem having all these organizations producing guidelines. It's that we decide that we have to do it. And we know that in Sudan already we have a breast management program, but it's not implemented. And it's very easy to put our guidelines as pathologists, as the radiologists are going to do. They are going to put their guidelines into this program. We put also our guidelines that breast in the lab should be handled like this, and this is our protocol.
Okay. لأنه في lot of details، بالذات الكاب عنده lot of details. الماشينز اللي انت استعملتها، مش عارفة الشركة اللي انت استعملتها، they put a lot of technical informations because it's going to, as you said, it's a teamwork and integrated with other departments. So you should know that مع ناس الراديولوجي لأنه الكاب عنده a lot of details.
We have to at least to base our protocols on those of the like the international collaboration, and then develop slowly and compare with our neighbors, and then go on from there.
Okay. Thank you,
as a
Nadia.
basis. It was good hearing you.
شكرا. نتلاقى قريب إن شاء الله.
السلام عليكم ورحمة الله. دكتورة نادية. دكتورة نادية, يعني really it was so interesting lecture.
I hope it was good.
Thank you very much يعني to inform us about your condition and to take us inside your lab.
Thank you.
We thought that radiology is really يعني challenging, but now we understand that you have more challenge than us.
The thing is, it's a different challenge. I don't have the patient. I just have a piece of the patient, and I have a sample that is not totally in my control. It's taken before. You see, like in Soba Hospital, I remember one of our very good technologists. He used to come even when he's sectioning. Dr. Nadia, I'm going to the theater, he says. I think they have problems with formalin. He knows the people in Soba, so he knows all the staff there, and he goes and say, show me your formalin. And then they come with, I said, formalin, Allah, we ran out yesterday, but we didn't come to you. And then he makes a fuss, and he's, mashallah, a big guy, and they really get scared of him. Oh, he's very benign. It can tell you that we have to reach outside the lab and do it on our own, you see, and hopefully eventually can set in a system of quality control. This doesn't happen.
Yes, you are right. There are a lot of challenges. Yeah. Yeah.
I see there are many hands up. Arwa, Asil, and I cannot read Mr. somebody.
السلام عليكم.
عليكم السلام.
يا مستر الراحل ولا الراحل ده محمد علي عبد الله. دكتور نادية، كيف الأحوال؟
أهلا وسهلا.
شكرا، بس أنا عايز أقول لك شكرا، وكويس إنه سمعنا صوتك بعد أكثر من سنتين يعني.
أي والله.
بعد ما راجع.
الحمد لله.
شكرا.
عفوا.
طيب دكتورة نادية قبل قلت لي ما شاء الله إنه ما عندي كلام لساعتين. عارفة الآن تميت الساعتين تماما. كملت الساعتين تماما.
كان ممكن ساعتين زيادة.
لا تمام جدا، ما في أي مشكلة، ما في أي مشكلة. ندي فرصة لحد يسأل سؤال وندي فرصة لدكتورة رودينا تقدم الكيس بتاعتها. إذا آخر سؤال، إذا كان سؤال أو أروى لازم تعلق يعني.
أروى وفي أصيل.
ما في مشكلة، نديهم الاثنين. طيب ما في مشكلة، كويكلي عشان نمشي للكيس بتاعت رودينا.
طيب السلام عليكم ورحمة الله وبركاته.
أروى ازيك؟
أنا والله سعيدة شديد إن أنا قاعدة أتفرج فيك من قبل وبسمع في صوتك، وكمان بتحكي لنا عن حياتنا اللي إحنا تقريبا فقدناها شديد يعني. أنا ريحة الفورمالين والزايلين جاتني طبعا يا دكتورة نادية، يعني I was really nostalgic وما عرفت أعمل شنو أساسا، لكن يعني خلينا نكون بروفيشنال شوية نتكلم عن الموضوع صراحة جميل شديد. وعارفة يا دكتورة نادية يعني الريسنت ادفانسز كلها بقت في الارياز دي بتاعت البري اناليتيكس، وانه what is urgent في الهيستوباثولوجي ده بقى عنده so many definitions، و200 انا اقرر اودي للرابيد processing و200 اعمل الريبورت on over the phone والام دي تي meeting وكده يعني الادفانسز كلها you touched upon them. وانا بطالب انه المره الجايه تعملي لنا frozen section، لانه بجد يا دكتوره ناديه it was really excellent outstanding. يعني انا حسيت انه انا كانه قاعده بتعلم من اول، يعني بعد شويه بتذكر انه انا ما عارفه، لكن حقيقي يعني بجد حاجه يعني outstanding بجد يعني. الله يديك
إن شاء الله we take it up. إن شاء الله we take it up. ما أقول من الآخر لأنه في الآخر we were struggling. إن شاء الله we take it up من الأوقات اللي نحن كنا بنحاول. عملنا cancer registry
أيوة.
was revived ودخلنا system في stack. الكلام ده له أكثر من 10 سنين، وكان برضو I had an appointment for a company in Sudan that would come and make a presentation for rapid processing. وكنا حنقسم العينات زي الاندوسكوبيك والكور تمشي وتطلع في نفس اليوم. يعني نحن وصلنا ستيج دي في السودان إنه المكنة كانت جاهزة وكانت الشركة ممكن تجيبها لنا ونلقى لنا طريقة نعملها، لكن then it started all breaking down. So hopefully we started that point إن شاء الله.
على كده شجعتونا، شكلنا هنعمل المحاضرة مرتين في الشهر.
طوالي.
عشان تكفر كل السبيشاليتيز.
Maybe
ده كلام ده شيء مشجع جدا يعني. شكرا لكم.
Yeah, Rehab, you have to sort of help us, and maybe we can start doing also, as you as a society are doing, we start doing as a pathology society.
إن شاء الله.
لا نحن نرحب بكم لحد ما السوسايتي بتاعتكم تقوم، لكن نحن مرحبين بكم تماما.
I'm a society بتاعتنا قاعدة. Actually, I am
موجودة.
Actually, I am heading it, but activities are at a standstill completely. So if by doing lectures we can start reviving it, it would be very good.
إن شاء الله لحد ما تعملوا لها refreshment برضو you are welcome.
Thank you.
أيوة ممكن نبدأ.
هي طبعا الحرب دي عملت المشاكل دي كلها.
أيوة
ما في
نبدأ أول حاجة بالتوأمة مع ناس رباب ديل، نعمل توأم مع ناس رباب ونعمل joined sessions إن شاء الله. لكن يا
طبعا
دكتور
مهم. وبعدين اهم حاجه يا جماعه انا منتظره الراديولوجي باثولوجي ديسكوردنت اند كونكوردنت
Exactly, that would be
مهم جدا جدا.
لازم اللكشر دي كلنا نجتهد فيها من الان، وكل زول يحضر الكيسز بتاعته. يكون ممكن كده ياخذ وقته ان شاء الله.
ان شاء الله ان شاء الله.
يلا أسيل تسأل سؤال عشان نمشي لرودينا منتظرة من قبل. أسيل اتفضلي.
أسيل دي انتي يا رباب افتكر ده الاكونت حقي اسمه
ايوه صح.
ايوه
صح
ده التليفون
ايوه صح. الأسيل انا داخله بيه افتكرت في أسيل
ده
واحده
نفس
ثانيه. لا خلاص
اوكي. لا
على كده خلاص. شكرا لك يا دكتورة نادية، وشكرا لك يا دكتورة سلوى يا دكتورة أروى، وجميعكم نشكركم شكر كثير.
شكرا لكم انتوا كثير.
شكرا لكم.
شكرا لكم.
الله
شكرا
يسلمك.
كثير.
دكتورة سلوى عشان تقدم دكتورة رودينا. سارة المك are you there؟
لحد ما تلمي في سارة يا دكتورة رباب، عايزة بس أشكر الحضور اللي عندنا ما شاء الله، بحضور فيهم دكتور محمد علي اللي هو كان معانا في المغرب يا دكتورة سلوى لو بتتذكريه، دكتور أيمن أبو الجوخ وآمنة فضل وصفية وناس من ستاك وناس من سوبا، كلهم حاضرين في الجميل دي. ودي حاجة وابتهالات كمان ما شاء الله تبارك الله.
ايوه انا ما رسلت السيشن لكل الجروبات بتاعتنا.
ايوه الحمد لله ان الناس قدرتهم.
ايوه
يا ريت لو كنتوا رسلتوها.
ايوه الحمد لله
كان حيكون الحضور اكبر.
لو من بدري كان الحضور بيكون اكبر، لكن نكست تايم ان شاء الله.
بتخيلكم انه الناس بترسل سارة شكلها عندها تكنيكال ايشو وشاح ولا نهاد. you can introduce.
لا سارة
دخلت.
سارة شايفة فتحت المايك بتاعها.
دخلت كويس. دخلت. لا خلاص
اوكي
can somebody so that you can present the case, can somebody unshare me or do I do it? How do I do it?
انت اللي عملتي الشير قبل يا دكتورة نادية.
ايوه
اذا انت you have to unshare yourself.
تعقونا بالعلم في الهيستوباثولوجي. الله يديك العافية.
get back to me لو في أي queries حتى لو اتكتبت لكم.
بإذن الله إن شاء الله. يلا بس بحتاجك to make دكتورة رودينا as a host من البارتيسيبنت.
السلام عليكم، أنا دكتورة رودينا راديولوجيست دفعة 2022. عندنا كان كيس interesting discussed with دكتورة رباب و prepared by دكتورة هند الله يديها العافية، و it was my case يعني in my job. طيب يا حبذا لو تشاركوا معنا، أنا عارفة إنه شوي زمن متأخر لكن حاولوا. طيب كان عندنا patient 35 years old female. She has no complaint, just came for checkup as she had a family history of aunt with breast cancer at the age of 45. Basically, the referring doctor asked for breast ultrasound, and it is done busy by ultrasound technician in our hospital. Then we just check after them if there is any need. Here the technician came and told me there is multiple different size cysts as the fibrocystic changes by RAD2. Who can describe this cyst?
Radiologists. Are there radiologists with us?
What is the size of this cyst, if I may ask?
About 2 centimeters.
So this is one cyst. You said multiple.
Yes, there are multiple. Yes,
Yeah.
multiple different sizes.
She want you to describe this one.
ما أنا طبعا يا رباب ولا شنو؟
Selection. If you like to describe it, you are welcome. For anyone, the description for any who interested to describe this lesion.
أنا شايفة
Mhm.
شوية يعني ما زي العادي اللي بنشوفه ولا شنو؟
شايفة شنو؟
ماجدولين ده رفع يده.
حبة.
You are welcome.
السلام عليكم.
عليكم السلام.
أول حاجة حابة أشكر الدكتورة نادية. nice to hear from you. الليكشر كانت ممتعة صراحة. طيب بالنسبة للليجن دي عندي superficial oval shaped irregular deeply hypoechoic lesion with surrounding hyperechoic rim. For me this is a suspicious lesion as the patient is young. In my country we do mammogram from at that age and 35 we are going to do mammogram and MRI for further characterization. This for me it is by RAD0. I need further radiological imaging.
Okay, Magdalene. 1 minute. I agree with you. You said you raise the level of suspicion. Okay. Yani excellent that you pick subtle suspicious features. And I agree with you. But in your management, you jump to to further evaluation with other modality before you complete the evaluation by ultrasound. That is the only point I'd like to emphasize. Still, we have to consume to analyze the lesion itself here in this image and to see further ultrasound image. Do you agree with me?
Yes, right.
Yes. Can I ask you, what are these bright lines within the cyst? What do you think about this?
This likely to be a desmoplastic reaction around the cyst.
No. I'm not asking about the rind that's around. I'm asking about what is inside the lesion. You have seen
inside. Yeah. Okay.
Mm-hmm.
Yes. This is I need another technique to further evaluation. Maybe nodules, parasitic nodules.
Yes, it can be reverberation artifacts, or it can be echogenic. Yes. It can be echogenic component within the cyst. So I have to clarify these things before jumping further. Another point. If you mention, okay, suspicious features like echogenic rind, what is the positive predictive value of echogenic rind? For all of you, the positive predictive value of echogenic rent. It is 74% or 75%. So it is at the level of BIRAD 4C. Why you grade the lesion as BIRAD 0? You have already signs, put the lesions at the level of BIRAD 4C. If you are confident that this sign is rent, that means this is BIRAD 4C. Another issue, you have said that it is hypoechoic. At this level, these lesions appear like a cyst. It seems to be anechoic, apart from this line that might represent internal echoes, okay, echogenic material, or a reverberation artifact. We need to clarify it, as you said, further. But يعني it is زي ما بقولوا it's good that you have mentioned the echogenic rent from the beginning, and we need to distinguish from the thin echogenic wall of the cyst, and especially the important point, especially to look for the side of the lesion. This where the echogenic rent is visualized. Go ahead, Dr. Rhodiana. Nice. Thank you, Dr. Magdalene. Stay with us. It is very, very good and excellent even to pick these signs from the beginning. Go ahead.
أيوة
معلش، ما عندي سؤال قبل ما نمشي، ممكن ولا ما ممكن ولا في الآخر؟
لا يا طوالي.
هي انتوا describe انا ما بعرف الراديولوجي، انتوا describe انها irregular dual circumscribe ولا انا غلطان؟ الريجولاريتي مش بتكون زي اشعة الشمس كده يعني؟
هو دقيقة منو اللي بيتكلم معانا أول حاجة؟ أهلا بك.
أنا دكتورة آمنة، افتكرت بيظهر عندك اللي بيتكلم. معاكي دكتورة آمنة الهيستوباثولوجيست، لكن هي منجد إن هي irregular mass.
طيب
الirregularity مش بتظهر زي الشعاع كده؟
It is an oval mass. I did it here an irregular. لكن I accept if she mentioned it is an irregular, I will accept that. Why will I accept? خلاص؟
أيوة.
Stay with us and I will let you know why it is an irregular.
Okay.
خلاص? Now it is apparently
oval in shape.
That it is an oval. So if she mentioned that it is an oval mass, is acceptable. If she mentioned it is an irregular, it is acceptable. خلاص? Just stay with us and you will see how it is an irregular mass.
Okay.
You are welcome. Continue, Rhodiana.
زي ما قالت الدكتورة مجدولين، عندنا الإيكوجينيك ريند. شوفوا بالناحية دي كيف الثيكنس، وهنا كيف الثيكنس، وهنا برضه. this is not the كبسول اللي بنعرفها حق البيناين ليجنز. الشيء الثاني، احنا متعودين سيست بالحجم ده المفروض يكون في posterior enhancement، هنا ما في. almost التيشو يعني زي المكان اللي ما في.
posterior enhancement is there but it is faint. It is fainter compared to the size of the lesion زي ما قالت. خلاص؟ very faint. Okay.
طيب هنا برضو احنا لسه في البروب اللي هو 15 او 15 ميجا هرتز. هنا ستارت انه يظهر انه it is not just revibration artifact، مع انه هنا بقيت more circumscribed لكن even بدأ يظهر. فبالتالي احنا عندنا خيارين. next step ايش المفترض ان احنا نسوي؟ في احد عنده فكرة؟ if you are scanning the patient, what the next step?
She mentioned before, Dr. Magdalene, she told you she need to go for
mammography.
No, not mammography. She mentioned
Doppler.
Vascular. Okay.
She mentioned Doppler.
Okay. Doppler هي next step فعلا. في أجهزة يعني عندها high frequency زي 24 ميجا هرتز. هنا طوال ظهرنا لنا إنه this is not a cyst. It is a solid but deeply hypoechoic. وظهر بدأت عندها multiple ductal extensions حنشوفهم في الصور الجاية بالبروب اللي هو 24 ميجا هرتز.
دقيقة أرجع إلى نفسها، أرجع إلى الصورة نفسها. طيب يا جماعة، not only duct، حتى الinternal echoes it is not only a nodule. Now it appear يعني it give more details. A higher frequency showed more details, showed heterogeneous echo texture. There is hyperechogenicity, not only single nodule, but there are heterogeneous echo textures. طيب, and the posterior enhancement now is even a bit more than in the previous image that demonstrate assist with fainter posterior enhancement and demonstrate thin ductal extension. So now it become even further suspicious features. Okay, and angular margin. Now, Dr. Anna, be with us, as I told you. Now, if you look for the right angle,
أيوة أنا موجودة. أيوة متابعة.
Where the ductal extension, now this is an angular margin. Okay, this is now start to become non-oval. There is an angular margin, that the margins are non-circumscribed. Go ahead, I'll show it to you again. Further signs.
Another image further showing the irregular margins with other thin ductal extension, and further show the heterogeneity of internal contents.
Now you can see the microlobulation of the margins. Okay, go ahead, and the ductal extension as Rhodiana mentioned.
Also, when we scan, we found more and more fine ductal extensions throughout the scanning.
Can you see the image on the right? Multiple branching ducts, posterolateral. Okay, and from the other one, higher ductal extension. If the duct's directed toward the nipple, we call it ductal extension. If it is in the other direction, we call it branching pattern. Okay, go ahead, and now here you can see the margins, more details of the margin with high frequency, and now it appear as indistinct margins. Okay, the margin are indistinct. When we have indistinct margin, we cannot label the lesion as and we have multiple ductal extension, we cannot call it as an oval lesion. This is an irregular lesion. Okay, go ahead.
And here at the end, the more ductal extensions and the echogenic trend also showed on this.
Can you see the angular margin here again from the left side?
Yeah, and
can you see this duct extension? It is really irregular. Can you see the margins? It is hyperechoic. There is no abrupt border between these hypoechoic lesions and the adjacent tissue. There is transition zone. So I have, and even this, the transition zone, you will see it further in the upcoming image to see that these borders, hyperechoic borders, is irregular. As Dr. Magdalene mentioned earlier in the first image, she mentioned that there is echogenic ring, irregular, non-uniform. So we consider this the whole is a lesion. Go ahead, Rhodiana.
طيب، فرضا انه ما عندنا البروب ذا في اغلب الاماكن، حتى عندنا هو في مكان واحد بس، ممكن نفتح الفاسكولاريتي وطوالي حتورينا انه this is not a cyst. هذه الفاسكولاريتي برضو بالهاي فريكونسي بروب، لكن عندنا دوبلر لل 15 ميجا هرتز شو يعني واضح انه في internal vascularity، ف this is not a cyst. It is very helpful when it is positive the Doppler.
But it is not useful if it is negative.
Yes, we cannot exclude presence of soft tissue.
Yes, you are right.
Here, this is the usual 15 megahertz probe. It is a highly vascular mass. It is not assessed more. As we say, positive Doppler is very useful, but negative is not useful.
وهنا we have to emphasize that we have to be patient, we have to adjust our setting, and we have to raise our hand and make it light pressure. If you compare this image of Doppler with the previous one, she improved, she adjusts her setting in the machines. So now the vascularity is even much higher than the previous image for the same lesions. So this is because of the adjustment. And this type of vascularity, we have a feeding vessels coming vertically, entering the lesion vertically. It is not just a capsular or a marginal vessels, which is really suspicious. And we have internal vascularity, okay, which is chaotic, without a capsular vessels. And if you look for the vessel, the blue one, you have seen it, and adjacent smaller red one inside without feeding vessels at the capsule. From them, you can see it arise and entering the vessels. These are interrupted and chaotic vessels without arising from a marginal or a capsular vessels, along with a perpendicular feeding vessels, are typical malignant vascularity of lesions. Okay, go ahead.
هنا بس بنوري الفرق ما بين ال two frequency probes. Make use of available machine facilities. يعني طالما عندنا دوبلر حنفتح الدوبلر، عندنا high frequency طوالي we use it خاصة in superficial masses. If there is deep masses, it's one of its limitation. And if we have larger masses or macro calcification that we cannot see the borders of the lesion, we can use the curve probe that we use on the abdomen. So we can adjust our machine according to the case of the patient.
Wait. Go for that one, please. Go for the, yes. Dr. Anna, you see, can you see the left side margin? Can you see the left side margin? This angular margin, this one?
Yes.
You see, this is outside the contour of the lesion. Because of this only, I will call it as irregular rather than oval mass. Okay? Go ahead.
Okay.
Go ahead.
Thank you.
Now, if you look for this, wait. If you look for these lesions, it seemed to be an oval, but yani, it was excellent from Magdalene that she picked the echogenic rent, the surrounding echogenic rent. That was the clue for or the hint that this lesion is not just a simple cyst or a fibroadenoma. You see, that is most likely a high-grade cancer, because high-grade cancer might appear similar to benign appearing lesions, but we even associate it with posterior enhancement, okay? And commonly seen in young ladies. Go ahead.
And here we are back to 15 megahertz just to show the echogenic ring. It is more obvious on this image.
Can you see it? That is the whole lesion, Dr. Amna. Can you show her the borders? This is the whole lesions, the hyperechogenic, this, and the central. Can you see the central now? Anechoic or hypoechoic, how it is irregular. Okay, we need to angulate. Yes, we need to angulate our transducer, okay, and sweep around the lesion to make sure exactly how does it look. Okay, how does it look? يعني we should not just put the probe like this once and from one face of the lesion just to conclude that this lesion is benign looking and that is it. We have to scan the lesion from every side, okay, and angulate and sweep throughout the margin to make sure from starting from a cyst. Now you can see it. It is like that. It is appear like a necrotic. This cystic component most likely just down يعني necrotic tissue and becoming like a cyst. Okay, and you see this thick hyperechoic or echogenic ring. It is a non-uniform. It is irregular. Okay, can you see it is an irregular? It is not uniform. At one side, it is more thicker than the other side. That is why the overall lesion is not an irregular or oval mass.
فعلا scrolling is the most important sign even in the vascularity في الدوبلر. مرات ما بتلقى الفيزل إلا في طرف الليجن. if you just satisfied with one image that is not vascular وفريز وخلاص you will miss it. scrolling to characterize the lesion and at the Doppler also. Here we should scan the axilla. It is part of the exam of the breast. And measure the cortical thickness. Here the right axillary lymph node show eccentric cortical thickness, just in the anterior part. It is exceeding our limit, which is 3 millimeter. So it is suspicious.
It is not only that, it is that the cortical thickening is asymmetric. Okay,
it's eccentric.
It is not concentric throughout the lesion. It is asymmetric and compressing the hilum. Can you see the hilum compressed from the side of cortical thickening? Yes. And not only that, we have some vascularity, this hyperechogenicity, cortical vascularity. Can you see this cortical vascularity? Also additional suspicious feature. Continue, Rhodiana.
When we see a suspicious lesion or the lesion that needs any intervention, we should measure the distance from nipple. If we have panoramic view, it is better, and the distance from the skin.
Show them the nipple relation of the lesion from the nipple here. You didn't show them the relation of the lesion from the nipple. Mm-hmm.
Here is the lesion and this is the nipple.
Okay.
And the distance from the skin also.
Sorry, excuse me. Where is the site of the mass? Is it upper, lower, medial, lateral?
You mean the clock?
Yeah.
It is 1 o'clock.
1 o'clock, yeah. Okay, thank you.
Welcome. And then the distance from the skin. Here we show more the echogenic ring. It is more clear here. See, it is irregular here. Very thick. Compare it to this side.
Can you see, Dr. Anna? Are you following us?
ايوه انا كمان حتى عندي سؤال ثاني. ايوه هل دي الماس
can you see yes. the hyperechogenicity here, how it is irregular? And if you even look from inside of the cyst, can you see subtle irregularity from within? Okay. Go ahead.
هي دي الليجن الواحدة. انتوا ما قلتوا هي مالتيبل، انتوا لقيتوا كل الفيتشرز دي في ليجن واحدة بس، صح؟
هذه كلها في واحدة. الباقيين كانوا عبارة عن سيمبل سيست. في صورة في الأخير يعني حنوريكم شكلها، يعني كلها تيبيكال سيمبل. دي الوحيدة اللي كانت فيها التشينجز.
اوكي.
Here, as Dr. Rabab said, most likely the lesion is the whole lesion here, and the central is the necrotic part.
Go back. Yes. Yeah. معلش دقيقة. Yes. So it is important the size of the lesion. This is all related to the lesions. This is surrounding reaction, okay? And irregular hyperechogenicity is part of the lesion, and we have to include it in our measurements, okay? It will be combinations of edema, desmoplastic reaction, and sometimes speculation beyond the resolution of ultrasounds, and these specules might include malignant cells. So we have to include all in our measurements, as you have seen in this image in green lines, okay, or purple dots here, okay? Go ahead.
So يا رباب الليد partially cystic partially solid على حسب الماركينجز التي انتوا عاملينها دي.
Yes, it is like that. This is most likely, you see, central necrosis, okay, within a lesion, or predominantly necrotic mass, okay, predominantly necrotic mass.
طيب, this is the high frequency أو Hooke probe. It is very helpful in angulation in places that we cannot reach easily, like the valley region between the two breasts. And it is really comfortable for the patient, for the assessment of the axilla, for the guidance of the biopsies, especially for small lesions. And the other, like other probes, it is real-time imaging. This for all probes, the same thing. The probe is mainly for MSK and superficial lesions, but we use the facilities also in the breast.
It is also helpful in the breast, especially for small lesions, okay? For small and superficial lesions, it can help us to evaluate such lesion, because it can be angulated and it has a small footprint.
حتى مفيد في المايكرو calcification, صح؟ إذا في any suspicion, even in the thyroid.
Yes.
It is very micro calcification. And sometimes when I cannot say it is a fat globule or it is true nodule or fibroadenoma, also I use it.
Okay.
Teaching point, what do you think? Do you have any point?
Further, we discussed some teaching point. If you want to add further teaching points from this case, teaching points. Go ahead, Rhodiana, because of the time. Continue.
Okay. The ultrasound is highly operator dependent, requiring careful attention to technique and skills. أي ملاحظة الواحد يشوفها لازم يتأكد. يعني we should not let the probe until we have a full idea that what we will write in the report. Here, the suspicious features appear very obviously. Careful assess all mass characteristics, including shape, margin, echogenicity, posterior features, associated elements such as echogenic ring and vascularity. Sweep carefully around the margin to assess for ductal extensions and branching pattern.
Okay, 1 minute here, 1 minute again. Go back.
Okay.
1 point. As a radiologist, as breast imager, we should always seek for suspicious feature first. When you evaluate the lesion, try to look and exclude suspicious features before to prove that this lesion is benign, okay? We should not just look at the lesion and say, it looks benign and that is it. We have to look to put in our mind there are many suspicious features regarding the margins. Regarding the ecotexture, what are the suspicious features? I have to exclude it. Exclude all the suspicious features, even in the associated features. Then conclude that this lesion, if there is nothing suspicious, then you can conclude is either typical cyst, as she's going to tell us, to show us how typical simple cysts appear, or this is like fibroadenoma. If it is a baseline, we'll say, yes, this is probably benign lesions or short-term follow-up. And that's, or if it is in follow-up, then we can say either further follow-up, or after 3 years, we can say, yeah, this is stable for 3 years with the same benign features. No need to go further for follow-up. Next.
Here the difference, and as we see on the right side, the cyst, it is well circumscribed, oval shape. See the uniform thickness of the capsule, and it is completely anechoic. The posterior enhancement, no soft tissue component, no vascularity. These are the typical signs of the cyst. Compared to this side with our non-circumscribed, here, see these margins here. We have break here. We have and then uniform echogenic rind. Here it is very thick, while here it is very thin. It is not anechoic. There is faint posterior enhancement regarding the size of the lesion. And I think the difference now became more obvious. The patient has many other simple cysts, like this typical simple cyst, but this was the only one with the suspicious features.
Yes, we have to emphasize on the difference between thin hyperechoic pseudocapsule or the cyst wall and the echogenic rind. The echogenic rind is thicker, okay? Thicker and non-uniform, and usually look for the margin of the cyst. These are weaker points where usually cancer start to extend into the adjacent tissue, not like anterior or posterior wall. You might see thinner hyperechogenicity anteriorly or posteriorly, and you get confused that this might be just a cyst wall. But when you look at, in this case, when you look for this hyperechogenicity on side of the cyst, you will make sure this is not the capsule. There are more thicker hyperechogenicity representing the echogenic rind, and you have to search for further suspicious feature. Go ahead.
That was last part of our lecture. My home message is ليس كل ما يلمع ذهبا. Take care of all lesions. Like this patient, she had many other cysts. So this is one of more than 10 of cysts. So every lesion should be characterized, even if you think it is just fibroadenoma or a cyst. No, give the all lesion its time.
Thank you, Rhodiana. It is really an excellent case, an excellent presentation. Thank you for sharing it with us. Thank you very much.
Thank you, Rhodiana.
You are welcome. وشكرا لك. شكرا نادية. يديكم العافية.
Dr. Abna, are you there? Is it clear for you now?
بالعكس والله زدت تفهم زي ما بقولوا.
Typical Abna is welcome. Good to hear you.
يعني كانت حاجة حلوة.
أيوة. Thank you for Magdalene that she picked subtle sign subtle suspicious sign from the first image, from the first glance. طبعا هي expert في expert woman imager دكتورة ماجدولين، شغالة في مركز الثدي، فعشان كده she got it from the beginning. يعني ما شاء الله عليها. ما عارفين موجودة ولا غادرت ولا الشبكة طلعتها ولا حصل شنو. ونلا stay with us وما سمعنا صوتها تاني.
والله شكرا، very interesting case.
الله
الله يسلمك.
يبارك فيك. يلا بس المسج انه نحن يعني to consume نفس الاستدي قبل ما to jump ل further imaging. we have to make use from the same study. يعني كلامها هي صح دكتورة بايدولين انه to go sometimes we need to go further يعني for other imagings. لكن هنا نحن we need first to consume الالتراساوند زي ما عملت. يعني هي الكيس دي ما شاء الله دكتور رودينا دي خريجة 22 مش كده يا دكتور رودينا؟
ايوه.
او ما شاء الله عليها، هي she picked the abnormality by herself وجابت لنا الكيس كاملة. يعني أنا just يعني I share her the discussion، لكن actually هي التكنيشنز جابت الكيس، هي شافت الحالة وشي observed الإيكوجينيك رينت. طيب وبعد ذاك اسمه شنو ده، بعد ذاك مشت فحصت المريضة رغم إنه يعني she did not deceived بالمالتيبل cystic lesions الموجودة والتيبيكال cyst. she picked إنه لا الليجن ده فيه هايبر إيكوجينيسيتي، فيه هايبريكويك رينت، ومشت فحصت المريضة لحد ما وصلت لأنها شنو، لأنها this is a suspicious feature، ولحد ما طلعت لنا كل الصور اللي طلعت ديت. فجزاها الله خيرا عن المريضة وعننا نحن ككيس، فعلا كيس فعلا teaching case. and thank you very much again.
الله يديك العافية.
Can I have a question and a comment. I would like to know how this one was diagnosed or what the report say. Pirate, you mentioned something like 4-3C.
دكتورة نادية،
أيوة.
الليجن ده بايرات 5.
اوكي 5 عديل، لانه انا ذاته من الكلام والدiscussion حسيت ماشي على اساس انه هو 5 عديل.
ايوه يلا لو كان بس الانترنال ايكوز او النوديول او احتمال او الايكوجينيك رينت لحاله. يعني الايكوجينيك رينت بتخليه بايرات 4C. الايكوجينيك رينت اللي هي 4 يعني ايوه بتخليه بايرات 4C. طيب دي الايكوجينيك رينت. طيب إذا كنت بس لقيت إيكوجينيك رينت مع الانترنال إيكوز كنت بخليه 4C. لكن بعد معاها كمان الفاسكولاريتي، التيبيكال مالجنانت فاسكولاريتي، يعني ما بس فاسكولاريتي، الباتن بتاعت الفاسكولاريتي نفسها تيبيكال مالجنانت، معاه ضغط الاكستنشن وما ضغط واحد.
ايوه
ما ضغط مالتيبل ضغط، ده انفلتريشن انفيجن.
Exactly, and so from your lectures, yes.
Yeah. وبدي مشكلة الفايبروسيستيك، احنا دائما بنعاني مع الفايبروسيستيك like this. دي مشكلة الفايبروسيستيك.
But this is very similar to thyroid, as you mentioned, Dr. Rhodiana, because in thyroid, when we work together at Royal, or at SOBA, you have so many nodules, and you have to categorize each nodule sort of by itself, and then decide on which you need to take the fine needle from.
Yes, you are right, 100%. Exactly. نفس الفهم. البريست والثايرويد the same. عندنا يعني من الحاجات من ال deceiving يعني بتاعت الكانسر which is leading to cancer missing is fibrocystic.
Yeah.
لو لاحظتي في المؤتمر كنا قدمنا كيسز كانت fibrocystic. تتذكري في الدكتورة آمنة قدمت حالة انه كان الكانسر ميس من 2014 لحد كم، فاكراها؟ كانت فايبروسيستيك. يعني الميست الكانسر ميست because لانه الباتن بتاعته ذاته البيهيفير. قلت لكم كنت اي سسبكت انها تكون لوبيولار، لانه لحد ما 2021 وكانت 3.5 قريبه ل4 clinically it was not palpable. It was not palpable. فموست لايكلي والتراساوند وايز كانت يعني ستل في الاول، فشكلها موست لايكلي انها تطلع لوبيولار خلاص. لكنها ميست لانه البيشنت عندها باك جراوند فايبروسيستيك changes
which makes life difficult.
yes. وانا عندي a lot of cases يعني في نص المالتيبل سيست، وبالذات لما يكونوا complicated. عرفتي بيحيرونا يا هو دي التشالنجز اللي قاعده اقول، قلت لك نحن فاكرين روحنا في تشالنجز ولقيناكم انتوا في تشالنجز اكثر مننا. فدي بصراحه بتدخلنا في دايليما، يكونوا complicated cyst وما تعرفي تاخدي بتاع، ولو المشين ما مساعداك في انك to characterize it further. ويا هو زي ما قالت مجدولين we need to go for the other images in this for the other modality for يعني to go back for mammography زي ما قالت عمرها 35 we have to go to mammography or to go for the MRI to characterize the lesion further. لو ما الالتراساوند كانت ما شاء الله زي التراساوند رودينا دي وساعدتها في انه عندها multiple facilities خلاص وتكنيك to make use of all of these to characterize the lesion. هنا في الحالة دي خلاص يعني she need mammography لأنه as a baseline، لأنه ده suspicious قبل ما يمشوا هنا. لكنها بالالتراساوند بس وصلنا لأنها بايرات 5.
Yeah, okay. طيب السؤال الكومنت الثاني كان what is the minimum؟ يعني البروبس دي حسي they're so important using the 15 and the 24 and using the Doppler. So what is the minimum where you can do a report, or is it I'm thinking now of the setup.
You are thinking about what?
On the setup. يعني لو أنا عايزة أعمل أقل حاجة acceptable شنو؟
acceptable 7.5.
Okay.
لكن طبعا it depends. لو البريست يعني so small and a lesion so superficial بتحصل جهجهة لما البرو بيكون low. 12 بيكون ممكن يجهجه و you might miss the lesion especially if it is an isoechoic lesion. طيب لكن في الهيوج بريست يعني احنا النافعنا في السودان ما شاء الله most of the female they have huge breasts.
Okay.
عشان كده our transducer اللي هم ما عندنا very high frequencies probe عشان كده شغالة يعني they are working لأنه البريست are huge. لكن لو عندنا small breast ديل والليجن superficial هيكون في a lot of missing.
Okay, so it is very important the equipment you are using.
خالص تماما otherwise دي من طبعا انت متذكره قلت لك الفتينه في الالتراساوند، لكن من الحاجات في التكنيكال بارت بيلعب دور كبير جدا
شديد
بيلعب دور كبير شديد جدا في الميسنج. ايوه
اوكي تمام. ثانك يو.
اروى بتسال، اروى عندها سؤال.
انا والله سؤالي يا رباب، اول شيء الكيس ما شاء الله جميله شديد وفعلا على قول آمنة يعني غيرت مفاهيمنا تماما، لكن الداير اساله انتوا عندكم the rest of the story، يعني هسي الريبورت بتاعت الكيس دي طلعت بايرات 5 صح؟
نعم.
عندكم باقي الجدمنت حصل شنو؟ الناس الكلينيشنز قرروا يعملوا شنو؟
الكيس ده هو لمس
بالله يا ولمس
جات في العياده اول امس وارسلتها واخذناها طوالي احنا هنا فريش.
thumbs up يا رودينا.
ما شاء الله ما شاء الله تبارك الله.
Yes, we recommend and we are waiting for what is they are going to do.
الريكومنديشن كان biopsy from both the lesion and the axillary lymph node، وإن شاء الله لما نطلع لكم خبر.
ما
شاء الله عليك، ربنا يحفظك.
آمين. الله يبارك.
اكسلنت.
ايوه
معلش نسيت إنه الفيديو ما مفتوح يا دوب نسيت.
نعم.
I was planned إنه أفتح مع الفيديو interaction، بس شفت إنه هسي مقفول بعد ما خلصنا.
ما فهمت عليك يا رودينا.
الفيديو الكاميرا.
ايوه معلش قدر افتحي الان ما في مشكلة. يعملوا دوكيومنتيشن الان. يلا اظهري ما شاء الله عليك، كويس ان شفناكي. طولنا منك يا رودينا. يلا قفلت الكاميرا. قفلت
كيف يا
الكاميرا.
رودينا؟ كيف
ما
حالك؟
قفلت، ما عارفة.
فاتحة ما شاء الله عليكي.
اتقفلت يا رودينا.
لا فاتحة يا رباب، فاتحة.
ليه انا ما ظاهرة عندي؟ طيب
لا فاتحة ما شاء الله عليها، منورة.
صغيرونة.
ايوه ايوه ظهرتي. ايوه الان ظهرتي عندي، ما شاء الله ما شاء الله. يلا خذوا صورة من حق الدكتورة نادية تظهر بالكاميرا وياخذوا صورة. ده السيشن بتاع رودينا ونادية.
دي شغالة وين رضينا؟
في سليمان الحبيب في السعودية.
في السعودية. اوكي.
ما شاء الله.
حالاتك ما شاء الله.
صغيرونة.
اكسلنت رودينا يا جماعة. والله سارة موجودة يا جماعة ولا غادرة؟ طبعا سارة دي من الناس اللي بتطلع بدري.
غادرت قبيل.
عندها بنوتة صغيرة، لا عندها طفلة صغيرونة، والله عندها طفلة صغيرة هسه بتكون غلبتها وكده، فنحن عازرينها وكده. ما دام وشاح موجودة ونهاد موجودة ممكن يختتموا لكم مع انه الجلسة جميلة وظريفة ولسه عندنا انترست انه نسمر مع بعض. ما صدقنا لقينا دكتورة سلوى كمان، أروى مع دكتورة نادية.
دكتور أيمن ازيك؟
ايوه
طولنا من أروى دي.
أروى ايوه.
طولنا من رودينا اقصد برضو. أروى
ومعانا أيمن أبو الجوخ وآمنة.
ما شاء الله كويس.
أيوة.
والله
ديل في السعودية.
ما شاء الله. you are welcome everyone. فإن شاء الله في كل سيشن، السيشن الجاي حيكون مع دكتورة اسمها من يوكي، كانت دكتورة منى سيرجون الشهر الجاي.
يس
السيرجون حيكون سيرجري، لكن مع كل سيشن إن شاء الله حيكون من الراديولوجيست حيقدموا لكم واحدة من الكيسز دي يكون فيها تيتشنج وكده، يعني إن شاء الله عشان نكون حاضرين يعني.
طيب نهاد صورتيهم؟
أنا غاية صورتهم.
تمام تمام كويس جدا. طيب في نهاية السيشن دي بنشكر كثير دكتورة نادية على المحاضرة يعني قيمة جدا جدا و very informative، وحلقت بينا يعني في داخل المعمل يعني، فكتر خير كثير. وقبل كده قبل كده قلت لك يا دكتورة نادية انه انا كنت فاكرة الباثولوجي ده حاجة ستريت فورورد وما فيه difficulties وما فيه مشاكل زي ما عندنا، فلكن كل مرة بتثبتوا لنا انه عندكم برضو نفس الحاجات يعني ونفس المشاكل والتشالنجز. فربنا يعين الجميع. ربنا يعين الجميع، ربنا يوفق الجميع. كمان بنشكر كثير يعني بنتنا الرائعة دكتورة رودينا على الكيس القيمة وعلى يعني مشاركة فعالة جدا منها ما شاء الله تبارك الله. ويعني قدرت ما شاء الله زولة خبرتها يعني بسيطة، لكن ما شاء الله عليها قدرت يعني تستفيد من كل الإمكانيات المتاحة لها في المكان اللي هي شغالة فيه، وتطوع الإمكانيات دي وتطلع لنا يعني الصور الجميلة دي واللي فيها يعني كمية من التيتشنج بوينتس يعني استفدنا منها كثير، وطبعا بمساعدة يعني الدكتورة رباب والإدارة للنقاش، فكانت كيس يعني حقيقي جميلة. وافتكر يعني دائما لما يكون مع المحاضرة في كيس يعني زي ما بقولوا بتثري النقاش وبتفتح الآفاق لأشياء كثيرة يعني، والناس كلها بتستفيد من الكيس. فشكرا لكم كثير، وشكرا للحضور الكريم الباثولوجيست شاركوا معنا كلهم، بنشكرهم كثير على مشاركتهم وحضورهم، وبقية الحضور كلهم بنشكرهم كثير الشكر يعني. ونتمنى إنه النشاط يستمر طوالي وما يتوقف إن شاء الله. زي ما قال الدكتورة رباب next month إن شاء الله حتكون معنا دكتورة منى، وإن شاء الله في الأيام الجاية نحدد مين حيكون الشهر اللي بعد دكتورة منى إن شاء الله. فإن شاء الله النشاط يتواصل ويكون مثمر والناس كلها تشارك فيه إن شاء الله. شكرا لكم كثير.
يلا أنا حابة أشكر دكتورة هند حقيقة. يعني أنا كنت أنا بعيدة على سفر وما معي لابتوب، ودكتورة رودينا جزاها الله خير هي ويلينج إنها تحضر الكيس، بس كان ظرفها ضاغط. فدكتورة هند كتر خيرها أرسلنا لها صور عبر الواتساب وحضرت لنا الباوربوينت ورجعناه لرودينا، وبعد ما جات من الدوام جات عملت لكم البرزنتيشن. فشكرا لهم، فشكرا لهم كلهم على التعاون. شكرا لهند يعني، وشكرا لرودينا رغم ظرفها الضاغط يعني. ربنا يتقبل من الجميع. طيب
إن شاء الله إن شاء الله
نستودعكم الله إن شاء الله.
شكرا جزيلا.
شكرا.
السلام عليكم ورحمة الله وبركاته.
نشوفكم. يلا سنة السيرجري ما بعرفهم الليلة ما ظهروا عندنا، يكونوا مشغولين، بس السيشن الجاي ما تختفوا يا ناس الباثولوجي يعني. خلوكم معانا
طوالي. رسلوا لنا اللينك طوالي، رسلوا لنا اللينك بس.
اللينك بكون في الجروب، انتوا معانا في الجروب. يلا انتوا الناس تحاول انه كل الناس تديستريبيوت اللينك في الجروبات الثانيه اللي معانا
ان شاء الله. ان شاء الله.
يلا يديكم العافيه. شكرا لكم.
شكرا.
دكتور سعيد كويس انك يعني قدرت دخلت رغم الشبكه بتاعتكم الصعبه. سامعني؟ ما شكله ما سامعني.
لا يا ابو سامعك، بس انا عامل ميوت للميكروفون. كيف حالك؟ ان شاء الله طيبه يا بوس؟
الله يكرمك يا رب، انا سعيده انك موجود.
والله وصل السيشن قيم ومفيد جدا، وربنا يتقبل من المقدمين ان شاء الله.
ان شاء الله.
يا بوس، قبل الناس ما تغادر، بالنسبه للكراتيريا بتاعت الليمف نود انه يكون اكسنتريك كورتيكال سيكنينج دي،
أيوة.
يعني انت لقيتها بس هي براها يعني. انت اصلا احنا اصلي مرت بينا كم حاله مع دكتور صلاح انك انت يعني بالنسبه لك ما فيها ليجن واضح كده، لكن تجي في الليمف نود بتلقى. السؤال هي يعني الحكايه نسبتها كم، ولا السسبشن بتاعها كم؟
يلا دي انت ما عندك 6 تايب، عندك 6 تايب في الليمف نودز، وكل تايب عنده يعني بوزيتيف بريدكتيف فاليو، فدي بوردر لاين. طيب دي تقريبا تايب 4 خلاص. تايب 4 يعني 59 something like that. البوزيتيف بريدكتيف value. It can be reactive or it can be malignant. So it is just a suspicious. In a setting of malignancy, we can say this is a suspicious lymph node. It has to be biopsy to confirm it is malignant or not. لكنها it is suspicious. لكن if you have no, يعني there are many criteria. عندك disproportionality، عندك a lot of issues you have to consider it while you are evaluating. إذا ما عندك cancer وعندك lymph node like this، ممكن بس تكون she cut her finger في المطبخ، يكون that is the cause for the lymph node like this. طيب لكن it depends يعني ممكن تشوف إذا كان عندك lymph node single lymph node like this disproportionate features مع adjacent lymph node at the same group or at the same axilla or to the contralateral axilla, then you have to raise the level of suspicion and alarm. Okay?
تمام لا كثير، لانه هي احنا هنا ما عندنا ماموجرافي، بس بيشتغل بالالتراساوند مع مرات يعني ما
يلا دكتورة ريم عملت سيسيس في الليمف نود، وعملنا ووضحنا الكرايتيريا دي كلها فول ستادي. ممكن ترجع للسيسيس بتاعتها، حتلاقي فيها كل الكرايتيريا موجودة. أنا ممكن برسلها لك بتلاقي فيها everything، كل الديتيل.
تسلم يا أستاذ، الله يجزيك خير. الله يسلمك.
وجزاك
الله يخليك.
يلا الهوست منو عشان يكتب يعمل leave for everybody. Rhodiana, you are the host.
رودينا ممكن تعمل كده.
Rhodiana, you are the host now. You can يعني ممكن تنهي الاجتماع.
اوكي هشوف من وين.
For everyone زي ما قالت قبل دكتورة نادية، ما تغادري انت لوحدك، تنهي
خلاص
الاجتماع للجميع.
خلاص تمام اوكي لقيته.
طيب
يلا نستودعكم الله، مع السلامة.
مع السلامة، نستودعكم الله.